Hello, my name is Dr. Phil Huxley, GP, Chair of East Lancs CCG, husband, dad, appraiser, teacher, first aider, singer, doctor with authority and the ability to influence. I'm all of those things and more besides, but I've been asked to talk about compassion from the perspective of the clinician. And I guess having thought about this, then actually thinking about the clinician and all those other things that I am, makes me think, actually, can I separate me from clinician from me from all those other things? And probably not. Okay. So a question, please. I'm not going to pick on anybody, but I would like you to put up your hands. If you have seen compassion delivered well. Yeah, so that's virtually unanimous. And again, put up your hands, please, if you can say that you've seen care delivered really without compassion. I think that's virtually everybody also. I mean, I wanted to ask really, would I pass the compassion test? Can I be a compassionate clinician and yet not exercise compassion in other aspects of my life? And if I'm compassionate at home, will that automatically transfer to compassion at work? I'm not certain. There isn't a compassion test, but we are judged on whether we are compassionate. From the first encounter with the patient, a judgment is made. This person, this clinician, is a compassionate person. And that affects the whole of that consultation, the whole of that interaction. It affects the outcome in terms of experience, both from the perspective of the clinician, but more importantly, from the perspective of the patient. So what is compassionate care? Defined as how care is given through relationships based on respect, empathy and dignity, and described as intelligent kindness and central to how people perceive their care. And if patients are to perceive care as compassionate, clinicians need to be able to recognise what compassionate care looks like, and more importantly, what it feels like. It's about the perception from the patient's perspective. Recognising lack of compassion. If we're going to be able to recognise when compassionate care is good, we need to be able to recognise when it's not so good. And I'll take you back to my own experience. I was a house officer, 1992. Completely different world then. I was working at Huddersfield. I was doing a 40-hour shift. I hadn't been to bed. I was exhausted. I was called down to see a patient, not dissimilar to this one, lying in a bed. She'd come from a nursing home. She was alone, she was deaf, she was frightened, and I had to take a history from her. I took my history as best I could, frustrated that it was taking so long. I had so many other duties to do, and came away from that interaction. And the nurse who was behind the curtain quite rightly said, "That was poor. You were unkind, your manner was not as it should be." Clearly I had excuses. I'm tired, I've got too much to do. I felt embarrassed, I felt ashamed. But I'm ever grateful that that nurse actually said to me, "That was poor." Because what I've been able to do since that time is actually, I think, care in a compassionate way. And that was probably because somebody pointed out to me that I wasn't always doing that. I don't always do it. I try my best. None of us can do it all the time. So I suppose the question that I would ask you, and I won't ask you to put your hand up, but if you see care not done in a way that you think it should be, have you said, "That was poor, that could have been done better"? So what does the GMC say about compassion? Well, actually, not a lot. It talks about care, it talks about good care, talks about respect and dignity, but actually it doesn't say a huge amount about compassion. So for care to be compassionate, we need to go beyond the GMC. And thank you, Jackie, for introducing us to the 6 C's. Values. Francis made us focus on values, and clearly the GMC, going beyond the GMC, needs to also start to think about values as well as duties. That patients must be the first priority and receive effective care from caring, compassionate and committed staff. However, I think actually the mistake we made with this is it was delivered for nurses, for midwives and for care staff. And I would argue that actually, as important is the receptionist who picks up the telephone, the GP who tells the patient, actually, you've got cancer, the oncologist who says, I'm sorry, we're looking at a palliative care approach, and the bereavement officer that has to support the family that go in for the death certificate. And so I think whilst this has been directed to care staff and nurses, I think we all have a duty to think about the values. We also need to absolutely understand that compassionate care, from a personal level, does require energy. And we need to think about looking after ourselves and our teams. So that's about planning, giving yourself time when you know you're going to be giving bad news. It's about having resilience so that actually, when things come along that are unpredictable, you've got that bit of an extra energy and reserve that you need to be able to be compassionate. It's about being non-judgmental, but recognising that actually being non-judgmental is a bit of an effort sometimes, and that can be draining because we all have our own prejudices that we cannot show. And it's also about having time to recover and reflect, both individually and importantly as a team. So compassion does define our culture, and as clinicians, which was the task that I had to share, we need to define that culture. So we need to champion. And fantastic that we've got so many people here today, but you need to be champions. You need to go back to your practices, go back to your small organisations, your big organisations, and say, I was here today, we were talking about compassion in practice, and we all need to be doing this. We all need to be champions and leading by example. We need to be demonstrating, we need to be positive role models for our peers, for our junior doctors, for our FY2 doctors, for our registrars. We need to support those colleagues that actually have a difficult time, recognising that compassion does take extra effort, and we need to support other colleagues that are having a difficult time. We need to challenge, like the nurse challenged me in 1992. We need to challenge when things aren't done so well, and we need to be able to question, why did you do that, and could you do it better? And we need to recognise that there's benefit, because caring compassionately gives benefit to the patients, but it also gives the benefit to ourselves. This morning I gave just about everybody in our building upstairs a small flower. And actually that's because I was feeling a bit fed up on the way here this morning. And I thought, how can I feel better? Actually, I can give a flower to people and that will make me feel better. And it genuinely did make me feel better. So in summary, our ability to be compassionate can improve. We can all learn to do better. Compassionate care will result in improved quality. Clinicians need to consider their own needs too. I say clinicians because that's what I'm asked to talk about, but we can all need to recognise our own needs too, recognising the personal impact of compassionate care. And good clinicians understand what a privilege it is to care for others. Compassionate care is central to caring and never an optional extra.